Hi there, we are occupational therapy students at St. Ambrose University. My name is Elizabeth Wynn.
My name is Brittany Zahn.
I'm Emma Elsesser.
And my name is Brett Coulter.
Thank you for listening in today. We are going to talk about what developmental coordination disorder is, otherwise known as DCD, and how OTs and OTAs can work together to help a child with DCD.
Today, we're going to begin with you doing a pre-lecture knowledge check to see what you know about DCD before we start. Then we will introduce you to the condition, talk about assessments and interventions used for DCD, as well as the outcomes we like to see from our treatment. Following that, we'll talk through a case study, and then you'll take a post-lecture knowledge check to see your progress and what you've learned.
Prior to beginning our lesson today, please either follow this link in the academia syllabus we provided or in the description box of this video below and fill out a pre-lecture survey so that we can measure knowledge gained through participation.
So just to introduce our topic, we're going to be talking about what DCD is, its etiology and prevalence, how a child and their family would manage this diagnosis, precautions practitioners need to know, comorbidities of DCD, and how DCD would impact a child's occupations.
So, a brief introduction to developmental coordination disorder. DCD can be described as an impairment of motor coordination that significantly impacts daily occupations, most commonly seeing areas of difficulty in academic achievement and activities of daily living. Children with DCD will often display excessive clumsiness, and you will commonly see delays in meeting motor milestones for their age group. The specific causes of DCD are unknown. However, there is a genetic link to DCD, and some other common causes are consistent with prematurity and environmental factors. 1.8 to 8% of children are diagnosed with DCD. This is a fairly broad range just because it's based on the diagnostic criteria that is utilized.
This condition is managed with a group of professionals, which may include occupational therapy, along with PT, SLP, a psychologist, teacher, physician, and/or vocational guidance counselor, depending on the setting. Precautions when working with children with DCD are general safety precautions to avoid injury from falls, such as working on soft surfaces and remaining close to the client to assist them with losses of balance as necessary. Common conditions seen along with DCD include ADHD, autism spectrum disorder, language disorders, dysgraphia, dyslexia, ocular motility disorders, and emotional disorders. Occupations which are commonly impacted by this diagnosis are education, play, leisure, social participation, and ADLs and IADLs.
Next, we'll be going through two common assessments that are utilized for children with DCD, consisting of the BOT and the school function assessment. If you guys are interested in learning more in-depth information or want to see this enacted, there are additional video explanations listed under the resources section in the academia syllabus.
The Bruininx-Osterazzi test of motor proficiency, otherwise known as the BOT-2, is commonly used in the pediatric outpatient setting, and it is a standardized and normative assessment that has excellent psychometric data. The assessment has a wide age range and can be used with children between 4 years old and 21 years old and 11 months. The BOT-2 has a total of 8 subtests that include fine motor proficiency, fine motor integration, manual dexterity, bilateral coordination, balance, running speed and agility, upper limb coordination, and strength. These 8 subtests can come together to create motor composites in fine motor control, manual coordination, body coordination, strength, and agility. And these motor composites will determine the areas that OTs and OTAs need to focus on for the child with DCD. There is a short form that is used as a screening tool, which takes about 15 to 20 minutes, and the complete form is the longer form, and it's the most reliable, and it takes between 40 and 60 minutes. The OTA may be able to conduct this assessment with the child, and the OTR will score and interpret the assessment, and they'll work together to create goals and interventions for the client.
Another assessment utilized with children with DCD is the school function assessment, commonly referred to as the SFA. This assessment is applicable for children being seen in the school setting. It allows the practitioner to identify strengths and needs as they relate to tasks the child will encounter within their school day in elementary school. The assessment is scored based on the practitioner's judgments and is criterion reference. The results of the assessment allow the OT and OTA working with the child to create client-centered goals and interventions to improve their performance on school activities identified as being a deficit. The OT and OTA can collaborate in this process, as either professional may conduct the assessment before it is ultimately scored and interpreted by the OT in order for further collaboration for establishing client-centered goals.
Next, we will be going through two commonly used interventions for this population. The interventions are task-specific training and cognitive orientation to daily occupational performance approach. Both of these interventions are evidence-based for this population to align with best practices. However, they are of course not the only interventions that can be utilized. Remember to always select client-centered occupation-based interventions to see the best outcomes.
So the first intervention that we're going to introduce for DCD is called task-specific training. So the goal of this is neuromotor training, and specifically the improvements we want to see are in balance and coordination. So the goal for these skills is to be enhanced in balance and coordination to support occupational participation of the child with DCD. So as this is a completely task-focused intervention, it's a top-down approach, and it focuses on the child's meaningful occupations. So for an example of task-specific training, we're just going to walk through a couple basic progressions of balance for task-specific training. Obviously, you would want to make these occupation-based to whatever the meaningful occupation is of the child. So Brittany, we're going to work on your balance today. The first thing that we're going to do in repetitions is, can you show me standing on one leg? So we're going to do this static, and then maybe to grade this up, I would want to have her do some dynamic balance. So can you reach over here and give me a high five? Good. How about over here? Awesome. So once she's done repetitions of dynamic standing on one leg, we would want to progress this again to try and challenge that balance, of course, incorporating occupation-based activities. So another idea from here would be single leg hopping. Brittany, can you hop on one foot? Good. Awesome. And so from here, what we may progress into is we could have Brittany do some jump roping or some skipping or any other skills that you may commonly see children doing in the school setting. So this just really supports that occupational engagement in PE class or recess, which then in part also helps with play and social interaction and all the functional mobility that a child may have in multiple settings.
The second intervention that we are introducing to you is the co-op approach. This is an evidence-based intervention program that is specifically supported for the use with children who have DCD. The co-op approach is also known as cognitive orientation to daily occupational performance, and it is a verbally based and highly individualized program intended to enhance problem-solving techniques to assist a child in generating their own solutions to resolve deficits in task performance. The co-op has 4 strategies that consist of skill acquisition, cognitive strategy use, generalization, and transfer of learning, and it focuses on using cognition as a performance support. In a typical co-op program, the child selects 3 different occupations or activities to learn over 10 intervention sessions. The occupations must be specifically chosen by the child in collaboration with their parents and or the therapist. Some examples of chosen activities may include handwriting, rollerblading, tying shoes, or cutting. Once the activities are chosen, the next step in the process is to implement cognitive strategies to solve performance problems and enable skill development within those chosen occupations or activities. The child and the therapist then focus on generalizing the activity across different settings and promote transfer of learning. The global strategy that is used with the co-op approach consists of goal, plan, do, and check. The child selects an individualized goal in collaboration with the therapist and the parents, then creates a plan that details how they will reach that goal and may include some of those cognitive strategies. Then they do it, and then they check to see how well the plan worked and if they need to revise anything. OTs and OTAs can both implement this program, and they work together by targeting regulatory skills in goal setting, planning, self-monitoring, and evaluation through encouraging the child to reflect on their current performance and areas for meaningful improvement. They also encourage the child to select, enact, evaluate, and adapt their performance through teaching various cognitive or performance strategies. OTs and OTAs can initially guide the child through this program while gradually encouraging the child to become more independent in the overall program.
So now we're going to be reviewing some outcomes that you may typically have a goal for or see following occupational therapy for individuals with DCD. Just as a disclaimer, remember that our goals and our outcomes should always be client-centered, and we want to be targeting those to the specific occupations and needs of the client. So these are just general ideas. Anticipated outcomes of participation in occupational therapy for individuals with DCD are derived from the OTPF and are as followed as participation in occupations. So primarily for our pediatric clientele, this is going to be participation in school and academics, participation in play, which could also enhance or inhibit social participation with peers and social development, as well as just participation and performance in ADLs and IADLs. Other outcomes we're looking for are functional improvements in those tasks, such as we talked about in task-specific training, and then also just an improved quality of life. Oftentimes, DCD can cause additional barriers for individuals in participation of occupations and activities, and we want them to have a sense of control in their meaningful occupations. So, continued OT services will support motor development during childhood and adolescence to address those barriers to occupational participation as they arise. So, as we know throughout development, there are a lot of different activities that we begin to partake in as we get older, and some activities that we will cease participating in as we age as well. And so, the barriers are likely to come and go, and being an OT can help address them in the context and environment as they come. And discharge may occur once goals are met or there is a lack of progress occurring. But as this is a chronic condition that is going to persist and present in different ways depending on what the child is participating in, OT may be something that is discharged and reoccurring later in the future. So for applicable modifications and adaptations you may use in activities and occupations for this population, some examples are classroom modifications. So you could change routines for the child, maybe changing their passing time so they're not having to ambulate and use functional mobility in the hallway when it's as busy with all their other peers and they're likely to fall. And you could also change materials and seating. So DCD, there could be some fine motor delays in writing, and so that's a time when you could provide different writing materials and adaptations, and seating as well to provide a stability and reduce the likelihood of a child falling out of their chair or injury due to DCD. Another modification you could make is keeping environments as predictable as possible. So one of the articles linked for you guys to read talks about just the activity of T-ball for young children and how children with DCD were more likely to be successful in making contact with the ball and being able to actually participate in the sport when the field and the setup of the tee and the ball and the bat were in the exact same place every single time. So this makes it really predictable for the child, and there's no different barriers to dodge that may be difficult for them to do with poor balance and coordination. And they're more likely to master that skill. So this can be applied in our co-op and our task-specific training and interventions as well. The third one is similar to LVST, big and loud, and just focusing on verbalizing those large movements during physical activity, just as a cognitive and verbal reminder to children to make sure that they're making safe, large movements so that their balance and coordination is enhanced during physical activity. And the last one is just advocating, maybe in the school setting or to parents, just for additional time for tasks to be completed. Sometimes with that level of discoordination and balance difficulty, it can be hard for a child to finish a task in the same time as their peer that does not have coordination difficulty.
So now it's time for our learning activity. And for our learning activity, you will be reading a case study in which you will pause after I read the case study, and then you'll turn to a partner or whoever you're with and explain how you would implement these interventions with that child. All right, so for our case study, Henry is a 7-year-old second grader experiencing difficulty at school with handwriting, participation in gym class, social participation with peers on the playground, and walking in the hallways. Henry commonly trips while walking and running, causing classroom disruptions. His teacher reports that Henry requires additional supports while donning and doffing his coat before and after school. Mom also reports difficulty with independent dressing of pants and shoes at home. So you're seeing Henry in the school setting to address his DCD problems. Turn to a peer and discuss how you would implement task-specific training for Henry through an occupation-based approach. And also discuss, would Henry be appropriate to use co-op as an intervention? Discuss with the peer how you would carry out this approach. So feel free to pause.
So now we're just going to wrap up a little bit with a case study and share what our ideas were in relation to Henry. Just as a reminder, everyone is going to have different approaches and different ideas. And I know we gave you very limited information about Henry, so I'm sure you guys all came up with great ideas. Personally, what I thought of for task-specific training for question 1, I thought about using dressing as a modality, like we have Henry in the picture here doing. When I think about his school participation, I think about when they go outside to recess. If he's having a hard time donning his coat, he may not get out to recess at the same time as his peers, which is then impacting his social participation. As well as difficulty getting ready for school in the morning could affect his attendance or tardiness. And then also just that social piece of wanting to be able to getting dressed like all of his peers in the class are at the same time. So something we could do for task-specific training is just repetitive practice of donning and doffing a coat. We could modify this if it's fine motor needs, having different zipper attachments, practicing with larger clothes until he's ready to increase the challenge to his coat. There's a lot of different things we could do, but you can do a lot of repetitive activities with the different ways of dressing for Henry.
And another area an OT or OTA can focus on with task-specific training is his participation in gym class or or at recess. There's a lot of gross and fine motor that comes with it. So, for example, we could do like the balance progression at the other slide or intervention slide of just like combining balance progression with occupations that he likes. For example, if he likes hockey, then we can practice doing like focusing on his balance while coordinating his hand movements while playing hockey.
For the second question, Henry would definitely be an appropriate client to implement the co-op approach with. He may need a little bit more assistance in the beginning or guidance from the therapist and the parents just because he's only 7. So he may need a little bit more guidance in terms of developing appropriate goals and kind of the plan and do and check and all of that. But the main focus for the co-op approach is to first see what Henry wants to focus on. So I mentioned some common examples are handwriting. So that could potentially be an area to focus on and develop some cognitive strategies to assist him in that. But let's say he wanted to, like his main concern was playing with his friends on the playground. Then as the therapist, you would, in collaboration with his parents, focus on specific strategies or goals that you could help him see increased performance in that area.
So now that we are wrapping up the end of this lecture, we would really appreciate it if you guys would be willing to take our post-lecture survey. It's going to have similar questions as the pre-lecture, so you guys will be able to measure your knowledge gained after this presentation. Additionally, after submitting the quiz, you will be able to see your results, and if you have any questions that you did not get correct, be sure to go back in the video and review things so you are all set to interact with clients with DCD.